So to get us started, obviously our focus today is on health justice partnerships. As with our last Insights and Learning session, which was on referral networks and partnerships, this is not a new topic of discussion between our advice colleagues. The research of the link between health and justice has been consistently kind of researched and demonstrated over the last 20 years at least. And yet it's a topic that we do keep returning to, whether it forms the basis of a conversation about our users and the inequalities that they face, or we're talking about service delivery where partnerships are still piloted as new initiatives. While we'll be touching on the evidence demonstrating the links between access to advice and positive health outcomes today, we're going to take a lot of that as read. Emmeline will be circulating a link to the health justice section of our research library. That area has nearly 100 reports for anyone who is interested, who'd like to engage with the research around connecting these two areas directly. So our focus today will be on the partnerships themselves and what the key criteria for success is, what makes them challenging, and we'll also be exploring why we're still discussing scaling this evidently effective solution after more than a decade of dedicated work. To start off with, I'm really delighted to welcome Professor Dame Hazel Genn and Dr. Sarah Bearden to give us an overview of health justice partnerships and to talk us through their most recent study on partnership implementation success. So Hazel and Sarah, over to you.
Good. Okay. What I said was thanks very much for the introduction. Hello from me, and here's Sarah. We're doing
morning, everybody.
Hello. We're doing a quick double-hander at the beginning. I'm just going to do a very brief introduction and then hand over to Sarah, and I'll be speaking a bit later on about where we are in the current context. I'm actually delighted that this Insights, you said that we've spoken about this before, but I'm really delighted to see this Insights session devoted to health justice partnerships again, but also moving beyond the argument for them towards how do you implement and how do we scale up. And just to say, I noted that Guy Beringer is on the call somewhere, or in the room somewhere, and I just wanted to say from my own point of view, that I've been working on health justice partnerships with the support of the Legal Education Foundation for over 5 years. And I do think that the result of the work that we've been doing that's been funded by the foundation has helped to drive forward what I see as a kind of contemporary momentum in health justice partnerships. You made the point earlier that health justice partnerships are not a new phenomenon, and they are not. But I do think that there has been, that I think in the last few years, there has been a development in interest. And I think that health justice partnerships are really gaining traction, and particularly since in the kind of post-pandemic world, if we are in the post-pandemic world, certainly the post kind of desperate COVID situation. So I think there are, and I'll be talking about that later on. As was said earlier, we're not going to spend a lot of time talking about what health partnerships are, but I think it's worth just reminding ourselves. Sarah, do you want to just go on to the first slide? To just remind ourselves that when we talk about health justice partnerships, we're talking about collaborations between healthcare settings, healthcare professionals, and free social welfare legal services. And it's that collaboration, it's the partnership, whether it's a close partnership or a loose partnership, that is designed to address some of the most challenging determinants of health and to provide the best possible services to patients and clients to address in a holistic and effective way some of the difficulties that face low income and vulnerable people, particularly in situations of kind of constraint, as we are in situations of constrained economic services. So when we talk about health justice partnerships, we're thinking about a close relationship between free social welfare legal services and healthcare settings, not necessarily within them, but certainly a close relationship between them. And when we talk about free social welfare legal advice services, we're talking about the services that address everyday legal problems like difficulties with getting welfare benefits, difficulties of being in debt, difficulties with housing, inappropriate housing or having no housing at all, insecurity over employment, threatened unemployment, redundancy, those kinds of things, access to appropriate education, to community care, and difficulties around immigration. These are the problems of everyday life, and we know, and those people in the room who are from the health sector will know that these are almost identical with some of the most important social determinants of health. So social welfare legal services can be seen as, and ought to be seen as, a positive intervention that contributes to improving the health and well-being, particularly of low-income and vulnerable individuals and groups who face some of the most complex challenges, both in terms of their socio-economic condition and also in terms of their health condition. And Sarah, if you can go on to the next slide. And this slide simply shows the very close bidirectional link between health and law. And what we know from years of research is that having a legal problem, so having a difficulty at work or having a difficulty with your housing, having any kinds of those problems that you find that people are finding difficult to resolve or they don't know how to resolve, may very well and very frequently does affect both their physical and mental health. So on the one hand, you have the need for legal advice, the need for legal help, or an unmet need for legal help that may disproportionately affect your mental or physical health. On the other side, a person who simply is unfortunate enough to experience ill health when everything else in their life seems to be going perfectly well, a person who experiences ill health may suddenly find themselves in a situation where they have difficulties for which the law provides a solution. So poor health can lead to the need for legal assistance, and legal needs can lead to poor health. So there is this really clear bidirectional link, which again reinforces the point about the value. I mean, in a sense, it's almost obvious, the value of bringing together free social welfare legal services together with health services so that we can help to address the underlying causes of physical and mental ill health that arises from some underlying social or economic need. Going on to the next slide, Sarah, please.
Sure. So yes, so Hazel's given us that introduction about the rationale for Health Justice Partnership, which is of course a very strong one, but there is also good evidence for the benefits of Health Justice Partnerships and what these can achieve. So I've put here a link to an evidence review that we published a couple of years ago so that you can go away and look up the details. But just to summarise the main points coming from this, we know that integrating legal advice services within healthcare settings can help to reach people experiencing legal needs who would not otherwise seek help, partly due to their health condition. Of course, it helps to resolve those welfare rights issues because of the legal intervention, so problems with housing, money, employment, etc., which in turn leads to an improvement in living conditions through better access to heating, better access to food, greater social participation, etc. And we know that also this can contribute to improvements in health and well-being, particularly on the mental health and well-being side of things. The evidence is strongest with things like anxiety, mental distress. And it can also help to support healthcare teams, enabling them to respond to issues of poverty and inequality more effectively, and also to help manage some of the administrative issues and burdens that these welfare problems can create, and allowing them therefore to focus more on the health side of things and the care. So Health justice partnerships are certainly not new. They've existed across England at least since the late 80s, early 90s, when you start to find published examples of them. But they've never become a consistent or widespread feature of the landscape because they've not been adopted into policy, either health or legal policy. There isn't that coordination at the top. So they're very much local initiatives. They're responding to local needs. They're established on the basis of local relationships. And these services do exist across the country in pockets, and they're a very diverse group as well. So they work with different patient groups, they address different legal issues, and they have different ways of working in partnership and joining up that care, which I'll be touching on in a moment. And this study here, this map is from a study we did back in 2018, which also highlighted some of the real practical challenges in delivering these partnerships. Partly that could be to do with integrating across sectors and succeeding with that collaborative working aspect, but also just keeping the partnerships going. There was a relatively high turnover rate. There were always issues with resourcing. So we developed a new research project to understand implementation in more detail. And this study is something that I did as part of my PhD. So I've put the links there. I'd recommend the summary report rather than wading into the PhD thesis, but the link is there if anyone does want the details. So just a very brief introduction to what I did here. I was focused on this question of how can health justice partnerships be implemented successfully? So thinking about those different systems, what was working well, what the challenges were proving to be. And I was working with diverse partnerships across different regions of England. I had 9 services that I was working with in depth, and the research was based on interviews with the professionals in those partnerships, both the frontline, healthcare teams and legal advisors, the management staff and the funders as well. And it was based, on the interviews. So to give you some an overview of the features of these case studies. So I wanted to work with services that would reflect some of the diversity that I knew was out there rather than focusing on any one particular setting or way of doing things. So I chose case studies that were based in different healthcare settings, so in GP practices, in hospital clinics, mental health services, a range of different places. And I focused on services that were providing legal assistance, at least to casework level. So not just the one-off advice, but more in-depth and ongoing support. And that could be with a range of issues. Very commonly, it was welfare benefits, debt and housing. And there was a mixture in terms of the delivery, largely face-to-face, some remote advice. I should say I was doing this study during the pandemic as well, so there was lots of change happening at that time. In terms of the scale of the partnerships, that varied as well. Some fairly small projects, some quite large, reaching across whole counties, and they were funded through a range of different streams. So in terms of how legal advice can be integrated with healthcare, there are different ways of doing that. And in this study, I focused on the first 3. So where advisors were embedded within multidisciplinary care teams, this tends to be a more common way of working within mental health services and acute care settings. I looked at services where the advisors were co-located, so delivering the advice service physically from within that place of care, and also where they were taking referrals directly from the medical teams and social care teams, usually in addition to being located or working within those teams. In this study, I didn't look at the navigation schemes, partly because one of my main interests was in that collaborative working and how the health and advice teams were working together day to day. And if the system is based on working via an intermediary, that's not so likely to happen to the same extent. That's not to say that navigation schemes can't be useful. I'm certain that they can. And I'm also aware that there are some interesting hybrid models where there are specialist link workers or embedded welfare rights support within social prescribing, for example, although I'm not sure exactly how common that system would be. So this leads me on to the first outcome that I was looking at, which was collaborative working. So in my view, and as Hazel said, I think this really underpins the whole idea of partnership. It's only really partnership if it's collaborative. And there are real benefits of that two-way working relationship between the health and advice teams. So in the services that I studied, there was a fair amount of variability in the level of engagement between the teams. And in some of the partnerships, it was relatively limited. So the advice service might be located there, they'd be receiving referrals, but often it didn't go much beyond that. That was actually quite common, interestingly, in the GP settings. And in other places, there was a lot more going on sort of day to day. The health teams might be involved in identifying the needs, actively asking about people about their welfare rights issues, exchanging information. So we know, for example, that medical evidence can be really important in establishing somebody's legal entitlements and putting together a good case for them. Consulting with each other to understand the situation better and potential ways forward, contributing jointly to the casework and coordinating all of that, providing feedback to each other on how things were developing for the patients. And I was interested in, I guess, why this was and why some teams were so much closer in their ways of working than others. And so I looked at the influences on that, on engagement. And these were the main themes that I identified. So the first one, whether the teams were willing to work together. This was important. So how this included how positive the sentiments were towards the partnership. So did the teams really value that welfare rights service and recognise the importance for health, and did they feel that this was a really core and important as part of their role? So, for example, did the medical teams think that it was important to be considering those social and welfare rights issues and doing something about poverty, for example? Some of them absolutely did. Others sort of thought maybe this is a bit outside of my remit, not my job really. So some things that could help to build motivation among the teams were providing opportunities to learn about the partnership, to understand the role of welfare rights in health, and also providing feedback from the work that was being done and showing the difference that this was making for patients. The second thing about whether people were able to engage and work together. So this is to do with the practical side of partnership working. So it sounds really basic, but just knowing that the service was there and being aware of it, sometimes it's easy for that actually to sort of go unnoticed, and understanding, you know, what sort of issues can you refer? How do you actually refer? What are the practicalities of this? So definitely doing some work around promotion and awareness raising and engaging with the team so that they know what to do. Another issue, having simple workable systems to work in partnership, so making that as quick and easy as possible for people to engage. And when you're developing services, it can help here to talk to the healthcare teams and involve the staff in developing that, and just check in to see how it goes over time. Are there any sticking points that could be addressed? And lastly, this issue of having opportunities to actually interact and communicate and work together on a day-to-day basis, because sometimes there can be real barriers there. So definitely co-locating the services, if possible, can really help there. But if not, then, you know, having meetings and just creating those opportunities for the staff to come together and work together. The issues of confidence were mostly important in the early stages of the partnership. So it was important that the teams could get to know each other so that they could build those relationships and feel comfortable as colleagues. And also it could take some time to build up the trust between the services. It was really important that healthcare professionals had trust in the advice service if they were going to make a referral or exchange information, for example. That was really important. But also just getting used to new ways of working, developing those habits, because it could be quite a big change from what they were used to. So mostly this sort of came with time and experience of working together, but it could also really help to have somebody who was actively facilitating and championing that partnership. And if there were any, you know, sticking points or difficult relationships, just making sure that those got addressed. So why does collaborative working even matter? So I put this table here just for you to read back afterwards, really, because I know the text is a bit small. But just to pick out the main messages, there are benefits simply of having a link, whatever that link is, between the health and advice services. So getting those referrals in, locating the services if that's how it's going to work, so that patients can find their own way, just making that link so that the patients get the advice that they need. But if you can encourage greater collaboration, so more communication, more teamwork, it's beneficial for access because it means that those needs are being asked about and identified more consistently. It's also beneficial for outcomes because the teams will be exchanging information that's necessary for the casework, as I mentioned. It can be beneficial for patient experience because everything's coordinated a bit more smoothly. And it also helps to develop the knowledge and skills within the teams because by working together, both the health care professionals and the advice teams really learnt from each other. And that could make for, more skillful practitioners. That's what they were telling me, that they felt like they could do a better job because they had learnt so much from working with the other team. So it's worth encouraging where you can. The second outcome that I looked at was sustainability. This can certainly be one of the hardest things, I think, in health justice partnerships, and the services that I studied varied a lot in their age. So some were in those quite early stages. Some had been around a really long time, up to 30 years, a couple of them at the top. And 3 of them had been discontinued. That's the ones with the arrows there. And this had happened at different points. So, but in all 3 cases, it was to do with the resources and the funding for the welfare rights advice. So 2 had had their funding removed, 1 had had their rent raised and could no longer afford to operate in the health setting. So in my interviews with people on the management and the funding side of things, I wanted to understand what had influenced those decisions about resourcing and whether to continue supporting these partnerships over time. So these are the themes that I identified. I've used the same ones as before, but they're slightly different content. So firstly, whether the funders were willing to fund these partnerships. So there were a number of factors feeding into this. Alignment with strategic goals. So was the project contributing towards the broader aims of the funder? So that could be different things. It might be sort of anti-poverty, health inequalities lens. It might be improving patient experience, wanting to coordinate support more effectively. It might be trying to reduce pressure on healthcare teams. There are different reasons that these partnerships can come about. Also value for money. So was this a service that was really meeting an important need locally and delivering a high quality and impactful service? And also sometimes just personal views on whether this was something that they valued and wanted to support, that could feed into it as well. So I think how we frame the work is important. It's good to be thinking about that bigger picture and where your service fits into this and how to communicate about it. But one of the other issues that I came across here was who should be responsible for funding the partnerships. And often the funders I spoke to would be questioning their own role within this, because from a health service point of view, they might be thinking, well, this is not medical care, so maybe we shouldn't be the ones. Local authorities might be feeling that, this was a special service for patients in the NHS. So maybe, again, maybe it shouldn't be them, maybe it should be the NHS. And charities, again, sort of feeling that they were plugging a gap in something that really should be publicly funded. So there is this tension in interdisciplinary projects, and the danger is that it gets dropped by everybody particularly when resources are scarce and everybody's trying to save money somewhere. So joint funding arrangements could help with this. So the jointly funded partnerships didn't seem to have the same kind of tensions according to my observations, because it was more of a sort of a joint effort. The second issue of whether funders were able to fund the partnership, so how much money was actually available. Some of the funders certainly were in very difficult financial circumstances, and to give you one example of that, I worked with a partnership in the north of England that was local authority funded. It had been there for maybe 30 years. This was in a hospital setting, supporting people with HIV. It was extremely well valued and everybody wanted this, but with the extra pressures of COVID and the money that had been lost through that, they just couldn't afford it. And so I do worry slightly about the poorer regions where the needs are likely to be greater. And then confidence, this was about issues that could sort of reinforce the decision making, could tip it either way. So evaluation evidence, it was important to have some data to demonstrate what the service was achieving, particularly thinking about the funder goals, as I mentioned. Local reputation could have an influence as well. So where the services were really widely known, they were considered to be excellent, they were doing lots of promotion of their work. And strategic relationships were important as well. So between people at the management level, the funding level, so that those people could actually work together to plan and to support the partnership and develop that joint understanding and commitment, you know, what they were working towards together. So finally, some brief conclusions. I'd say there's no one size fits all approach in terms of designing the partnerships. If you look across the country, they do differ in their scale, they differ in their focus. There's different amounts of resources that they have available, different partners involved, different kinds of care settings. So there's not a sort of simple thing that you can just follow in terms of the design, but some general principles would be to make sure that they're designed in a way that's responsive to the local needs and context, and also do aim for good levels of collaboration, as I mentioned, to maximise the efficiency and the effectiveness if possible, and build and maintain the relationships to strengthen the partnership. And that goes for both the frontline teams who are working together, but also the strategic level relationships. And communicate the benefits, drawing on any information you have to really make the case for your work, to give it that hopefully extra support from your stakeholders. So for anybody who's interested in developing partnerships, we've recently developed a new guide to support the implementation of health justice partnerships. This is something that's currently out for consultation, so do have a look through it, and if you think of anything that would be good to add, or if you have questions remaining after reading through it, then do get in touch, and we'll be working on a new version. So it has sections on service design, on establishment, collaboration, evaluation, and hopefully it will be a good first step or starting point for those of you considering developing these partnerships. So thank you for listening. I'll leave it there. I put a link to our website, also our email if you want to get in touch, and a link to our Twitter. Although we don't tweet a lot, we are there. So thanks, everybody.
Thanks so much, Sarah and Hazel, for that. Really, really interesting. Please do, everyone, pop any questions that you have in the chat. We've got some time to cover some of those. And I noticed that someone did ask, although I think you addressed this, Sarah, the question was, how do health justice partnerships link with social prescribing? And from what you're saying, and also from our experience across the rest of our network, we tend to see that these two initiatives are quite distinct things. Is your experience that it's usually either a health justice partnership or a social prescribing, or have you seen situations where these two kind of initiatives overlap and intersect?
Yeah, it's a really good question, and quite a common one as well. No, it doesn't have to be either or, and social prescribing using link workers is obviously one way to connect people with advice services. Some issues, I mean, as I said, within the sort of detailed research I did, I wasn't looking at those link working schemes, but I obviously do know people that work in that way. And a couple of things to sort of think about there would be, are people following up on those referrals? But also the capacity of the advice services locally, because I think maybe it depends on the social prescribing scheme, but the advice services are not always funded, whereas the partnerships that I was working with were where the advice services were funded and brought in-house. So they were a dedicated resource for the local healthcare teams. So that's a couple of things to think about, but definitely social prescribing can help to connect people with advice, and the advice itself can of course be helpful for people in terms of resolving that issue. So it's not one or the other, but some of the partnerships that I worked with where they had that really close collaboration, there were definitely benefits for that, which I'm not sure if you would see in navigation schemes. I'm trying to think if there's anything else to say.
Can I add something? Because I agree with everything that you've said. I think that the advantage of a stable health justice collaboration, even if it's not co-located, has advantages over social prescribing. Where you have a social prescriber, you first of all have the difficulty of capacity. You also have the difficulty of the training and the understanding of social prescribers. And I do feel that there's a way to go with that. social prescribers deal not just with connecting people with social welfare legal services, but they need to know about a vast range of things within the local community. And from our point of view, certainly from my point of view, I think that the issues that we're talking about are absolutely fundamental questions of finance, questions of housing, security, basic issues that need to be dealt with often very, very urgently, and you need to know where to go. And I have spoken to some social prescribers, and I've talked to, in fact, I've talked to a number, and I've looked at social prescribing platforms where people have exchanges, and I know some of the challenges that there are with social prescribing. So they are distinct. Of course, they're complementary, but for me, there is a real difference between an established health justice partnership, an established collaboration, and what happens quite often in social prescribing, which can be much more serendipitous. It may work, it may not, but it's not the same thing.
And just to add also, because you mentioned those, can they blend? I have come across a couple of examples where there are specialist link workers. So that might be that they've taken a link worker and trained them up in welfare rights, or they've taken a welfare rights advisor and trained them up in link work. I haven't seen evaluations of that approach, and I'm not sure how easy it would be, because I imagine both those roles are really quite busy and challenging. But that's one idea, and it's a potentially interesting approach as well to sort of increase the level of knowledge about welfare rights issues within social prescribing schemes.
Thank you both. I have to say this chimes really a lot with the learning that we shared as well. So at our last Insights and Learning session, we had a session about community referral partnerships and networks, and there was one partnership there that was dealing with a lot of referrals from social prescribers, and they affirmed their need to run a lot more training and education initiatives with their social prescribing network, because it was great that they were obviously utilising this referral network, but that understanding about social welfare legal issues is obviously something that needs to be kind of curated and developed over time. Just one more quick question then from me before we move on. I know I started the session by saying, you know, we talk about health justice partnerships for a long, long time. There's lots of research out there, but even I was quite surprised to learn that there were partnerships that ran into the decades. And I just wanted to ask, because obviously sustainability and longevity is such an issue that we're talking about here. Was there anything that stood out to you from those projects as making them kind of too good to let go of? Although I understand, Sarah, one of them was actually then let go.
Yeah, very sadly, that one was, and it was completely to do with money, which was a tragedy, because that was also a service where the needs of that patient group were so high, you know, that when I was speaking to the healthcare teams, they were saying like 70% of our patients have welfare rights issues. We need this advisor within our team. So it was really wanted and needed by everybody. So I think in terms of the long-standing ones, there's no sort of pattern as in different, you know, there are certain models that last longer or work better because they were organised in different ways. One was GP practices, one was a hospital clinic, you know, it doesn't really matter in terms of that, but I think there were leadership is incredibly important. So having somebody, some of the long-standing partnerships were started by people that were incredibly passionate and just kept fighting for it, despite, you know, every now and again there would be an attempt to cut the funding, but they just wouldn't let it go. And they managed to convince other people to support it. And it was just that sort of constant fighting to keep these partnerships going. I don't think that ever goes away.
Sorry to interrupt, can I just say something? I completely agree with that. And what really has surprised me over the years in talking to talking to people involved in the health justice partnership is the extent to which very often a long-standing thing can come down to just some individuals in a local area. This is such a kind of grassroots movement. I mean, it's just reinforcing what we were saying earlier, that there is no there isn't a kind of overall strategy. And when you look into things, you find that there's some critical person, somebody on a local authority who's absolutely committed to this, or somebody on a local authority who has a background in social welfare legal services and absolutely gets it and keeps on pushing it. And there are people, so there have been people identified in different parts of the country who've been absolutely pivotal in keeping things going, just through force of their personality, their commitment to the idea, and they've been able to drive it through, which is wonderful. But actually, what we're talking, people are asking questions about how do you scale it up and everything, there needs to be both that kind of grassroots enthusiasm and drive, but at the same time, I think there needs to be something much more strategic, and there need to be far more strategic conversations about how we address some of the issues about sustainability. And obviously it comes down to funding in the end, but those are conversations that have to be had. You know, if we think this is a good idea, if we think it's good for groups that are really facing significant challenges and we want to do the best for them through our public services, we need to have the conversations and agree.
Absolutely. And just to give you an example of that, if I can, one of the areas where this had been really successful, I think the director of public health, his mother had been a volunteer at Citizens Advice, you know, he sort of really understood it and protected it. And so it does come down sometimes to those personal perspectives and whether people value it. But then what happens when those people move on? And that's sometimes when things can fall apart. So, you know, how do we support these in a way that doesn't just rely on the individuals? Definitely.
Absolutely. How do we have a framework that backs up and supports that passion and that dedication and that drive? Excellent. All questions that we will be coming back to later in the session. For now, I'm going to move us along. So Hazel, Sarah, thank you so much for that really thorough, taking us through the key elements of the delivery models, examples of best practice, and those key challenges. Just to note that any links that were shared in the presentations, we will get those out and we will circulate them as part of the follow-up. Thank you to everyone who's been sharing them immediately in the chat function as well. We're really lucky to be able to welcome Laura Arrowsmith, who's Head of Health Justice Partnerships at Maternity Action, who's joining us today, particularly as Maternity Action have another event on at exactly this time. So Laura, thank you so much for making the time for us today. And I understand you'll be giving us an insight into how the evidence and the structures that we've talked about manifest at service delivery level. Laura, does the evidence that Hazel and Sarah have been discussing chime with you in your work?
Yeah, absolutely. So I'm just going to take you through the work we've done at Maternity Action on health justice partnerships, and hopefully it'll pick up on some of the themes that we've already discussed this morning, actually. So yeah, thanks for the opportunity to be here. It's really nice to be here this morning. So I'm Laura Arrowsmith. I'm from Maternity Action. And for anyone who might not know Maternity Action, we are a maternity rights charity dedicated to protecting, promoting and enhancing the rights of all pregnant women, new mothers and their families to employment, social security and healthcare. So as an organisation, we run a number of specialist advice services, and we also provide comprehensive online information about maternity rights, as well as running a programme of research, policy and campaigning work. So as an organisation, we advise pregnant women and new parents through our advice services, which is staffed by our in-house employment and immigration lawyers. So we provide services covering employment and social security, which I'll say a bit more about in a moment. And we also run services that support vulnerable migrant women through our maternity care access advice service and our migrant women's rights service. So our health justice partnership work so far has been focused on the specialist advice that we provide through our maternity rights advice service. So this is focused on employment and social security advice. So we do, as an organisation, run a national maternity rights advice service, and that's typically oversubscribed. So our health justice partnership work has looked at how we can integrate the advice delivered through the maternity rights advice service into maternity services in specific locations, using the model of a health justice partnership, so collaborations that embed legal support into healthcare services and teams. Our maternity rights advice service provides free and confidential legal advice by phone and by email. And the service is staffed by in-house employment lawyers and experienced advisors who all have expert knowledge of maternity rights at work and maternity pay and benefits issues. So the service can support with a wide range of issues, some of which I've listed here. So we can help with things like cost of living concerns, so things like checking maternity pay and benefits, but also sorting out problems with employment and problems at work. So our Health Justice Partnership work at Maternity Action has developed over the last 3.5 years or so, and it's developed from an initial scoping project into 2 practical projects implementing maternity rights advice services, working with maternity services. And we've worked with a range of different funders on these projects. So I'm just going to take you through our experiences and what we've learned from implementation, and then talk about some of my own reflections and thoughts on challenges and opportunities. So a lot of the presentations that I've given so far on Health Justice Partnerships have been more about what we've been doing and how the service is there to support women, families and midwifery teams. So this is a slightly different presentation to one that I've given previously, and it's been a nice opportunity to reflect reflect on the work that we've done, and I hope some of the points shared will be useful and useful for the discussion session. So my initial role when I joined Maternity Action back in 2019 was a scoping project to look at how we could develop and implement a maternity health justice partnership, and that project was funded by the Legal Education Foundation. So there were 3 main aspects to the original scoping project, the first of which was service model development, so looking at what a maternity health justice partnership would look like in practice and how we could deliver that. The second aspect was evaluation, so how would we evaluate a partnership project, what additional evaluation measures would we need to build in to demonstrate the value of us working in partnership with maternity services. And the third aspect was policy influencing, so trying to raise awareness of health justice partnerships with policy contacts and with commissioners. So it's really great to be here today with Hazel and Sarah, because throughout our work we've drawn a lot on their research and their expertise in this area, particularly in terms of the evidence base behind health justice partnerships. So that research on the connection between legal problems and how that impacts on health, as well as the evidence for what makes health justice partnership services successful. And they've given us some really beneficial input and advice over the course of the work that we've been doing in this area. We also did some of our own small scale research through the scoping phase. So we did a small poll of callers to our National Maternity Rights Advice Service, just to find out whether people calling the service had already raised an issue with a health professional. So through that poll, we found that around 30% of callers had already spoken to a health professional about the issue they were contacting Maternity Action about, most commonly their midwife. And we also spoke to midwives in the scoping phase as well. So we spoke to midwives about, whether women and families were raising questions and issues with employment and income with them, what they did in those situations, and how they would like to see a partnership service work in practice. So as part of the scoping project, we have pulled together some briefing materials about health justice partnerships, including how they could benefit maternity services. So those materials are available on our website for anyone who's interested. But the overall aim of the scoping project was really to get to the point where we had funding for a pilot maternity health justice partnership that we could deliver in practice to test out the model. So we were actively seeking out commissioners and health contacts to speak to about our work during that phase and our proposal for a health justice partnership. And we spoke to commissioners about how a partnership service would make it easier for women and families to access advice, save midwifery time to concentrate on clinical issues by providing a referral route for when questions around work and income were raised in appointments, as well as supporting wider objectives within maternity services to address social issues that impact on health and well-being. So we had a lot of positive conversations with commissioners during that time, with maternity service contacts, but commissioners have a lot of competing priorities. So positive conversations didn't necessarily always translate into funding. But we were really fortunate last year to be commissioned by the Cheshire and Merseyside Women's Health and Maternity Programme for a 12-month pilot project with Wirral Maternity Service, and we've been really grateful to have the opportunity to work with the Women's Health and Maternity Programme in Cheshire and Merseyside and the local maternity and neonatal system there on this project over the last year or so. So through that project with Wirral, we launched a dedicated Wirral Maternity Rights Advice Service. That service was launched in June last year. And we've been working in partnership with the midwifery team, and in particular with a consultant midwife at the maternity service to develop the partnership and integrate advice from the Maternity Rights Advice Service into the maternity pathway. So working with midwives so that they know that they can refer women and families who have any questions and concerns around employment or income directly to Maternity Action. So what that's meant in practice is that we've had regular meetings with the consultant midwife about the service and the project. We've gone along to midwifery team meetings to talk about the project and the advice that we can provide. We've developed a range of materials to promote the service that have been delivered to midwifery teams to promote to women and families to let them know that the service is here. So one thing that the consultant midwife was able to organise was a service leaflet that went out in the appointment booking letter. So that meant that we were reaching women at an early point in their pregnancy journey, which has been really positive. And there's also been things like posters and social media materials about the service, as well as promotion that we've undertaken with other local organisations about the service. So the service was profiled on ITV News shortly after the launch, and I've included the link there for anyone who's interested. And I've also just included some really brief quotes, some feedback quotes. So the top one is from one of the midwives, and the second one there from a woman who's accessed the service. So just a quote from the midwife, and you know, this is a common theme that we found in feedback from midwives, that, you know, understandably midwives can't be experts in everything. Their focus is on the clinical care. So the service has been beneficial in providing a route for when women have those questions around work and income. And the quote, the second quote there, is just from a woman who's used the service, just saying that the service has provided, you know, practical advice around managing health and safety concerns in this instance. So in terms of key learning from our implementation of this particular project, I think the work in the Wirral it's just given us lots of learning really for how the model works in practice. So having done the initial scoping study, the way you think things are going to work in theory is not necessarily how they then turn out to work in practice. So I suppose I've just pulled out a couple of key things for me, which include the relationship we've had with the consultant midwife has been really crucial. So she has been absolutely fantastic in supporting the project. We've worked in a really collaborative way with the consultant midwife, and I think having that point of contact, that dedicated point of contact at the maternity service in terms of someone who is supporting the project in a very practical way has been really key in getting things done and engaging with the wider maternity team. I think one of the points that came up in Hazel's and Sarah's presentation was around, you know, really working in partnership, and as part of that we've needed to be flexible and adapt our ways of working over the course of the project. So I think one thing we had hoped is that we would be able to get some dedicated training time with midwives, which hasn't been possible. So we've had to look at other ways of getting information and about the service out to midwifery teams and engaging with the team, and we've done that through short 5-minute video presentations that have been circulated around the maternity team, as well as doing a walk around with the midwifery team. So our advice service manager went to visit the service and had conversations with midwives who were in the service at that time, and that just meant that it was a way of engaging with the team without it taking up a chunk of time in people's diaries. And those conversations, I think, were a really crucial and really valuable exercise, because it showed us that actually we do need to spend some time with the midwives, speaking to midwives to go through what the service can help with, and in particular how legal issues might present within antenatal appointments, and how issues that we at Maternity Action can help with or are already presenting within antenatal appointments. So I think I've got this right, that I've seen in a previous presentation that Hazel's given, that one aspect that's been highlighted is that recognising the need for legal assistance is not necessarily intuitive for health professionals, and I think that's definitely something that we have found in our experience, that understandably midwives are focused on clinical care, so it's understanding sort of that there is perhaps a legal need has been something that's that takes a bit of time. So I think I think one key piece of learning is that it's not been enough just to say we've got this service, it's really beneficial for women, it's here, and expect that it will get take up. So although one aspect, I think one kind of aim of the partnership service is to save health practitioner time in terms of that referral route, I think it does require some time from health teams initially to be able to engage with the service offer and what the project is about in the initial stages. And I think it's really important to recognise that even with a supportive health contact, it just takes time to embed new ways of working, particularly in a busy health team. So 12 months is not that long when you're trying to implement a new service approach and a new way of working, and those months have just whizzed by, really. And so a final thing I just wanted to pick up on, so some of the information that's kind of in the I suppose the Health Justice Partnership evidence base is about co-location, and co-location being I suppose a particularly sort of good model of Health Justice Partnership working, and obviously ours is a phone and an email service rather than having a physical presence in the health service. But I think, one thing that we found is that having that physical presence in the service is really important for reminding midwives that we're here, and also for, in terms of visibility for women and families. So we have done outreach and engagement work within the maternity service, speaking both to midwives, but also to women and families using the service. And I think that's been really important for kind of raising that awareness that the service is here. And I think that's a key piece of learning that we're going to be looking to take forward into our other projects, that we will have that engagement and outreach role sort of inbuilt from the start, so that we've got someone going to the service to have that ongoing visibility for the service. So we're taking the learning from our Wirral work into our new Greater Manchester and East Cheshire project. So this is a project that's being funded by the Department of Health and Social Care's Health and Wellbeing Fund, which supports joint working between the voluntary sector and the wider health sector. It's a broader project than the work that we've done in the Wirral. So as well as advice directly to women and families, the project is also supporting a particular strand of work working directly with employers. But one aspect of the project is delivering a dedicated Greater Manchester and East Cheshire maternity rights advice service, working with maternity services across the region. So as well as having that outreach and engagement officer role that I mentioned, another way that we're looking to adapt the delivery of that partnership working in this particular project is hopefully introducing a prompt question for midwives to introduce to introduce some consistency in how the service is introduced, and ensure that all women and families are made aware that the service offer is there. So that project started in December last year. So we've just launched the service, and we'll be carrying out a programme of engagement with midwifery teams over the coming months. We've had some initial positive conversations with heads of midwifery, and we've got the local maternity and neonatal system supporting the project, which again I think is really crucial to have that kind of level of buy-in at that level. And as part of the DHSE funding, we are required to appoint an external evaluator the project, which is something that I'm really excited by, in terms of being able to work with an external evaluator to perhaps look at our evaluation work and how we can develop that to show the value of the project. So we're working with NCVO on the evaluation. So I thought I would just wrap up with some general reflections on challenges and opportunities in terms of my experience over the last few years. So I think for me, I mean, there's sometimes been some uncertainty around using the language of health justice partnerships, and I think at a very practical level, at what point I mention this, I find, you know, whether I'm speaking to commissioners or midwives, I spend quite a bit of time thinking about at what point, you know, do I say, you know, this is a health justice partnership, because I'm never really too sure sort of how that resonates with commissioners, and I think particularly with midwives when we're trying to get across that we're, you know, working in partnership with them and what we need for them in terms of the collaboration. So I do wonder if there's just a question around how we sort of describe the work so that it's meaningful to others. And I think linked to that, and you know, this picks up on one of the conversations that we've already had this morning, but I think certainly in the scoping phase of the project, we spent quite a lot of time thinking about, you know, how we link to the social prescribing agenda, in terms of there being sort of overlap in health justice partnerships providing non-clinical support in health settings, but also trying to highlight that health justice partnership models were different, and could also address some of the drawbacks of that link worker model, particularly in the sense of, you know, link workers only being able to link to services that are available in the local area. So I think it was a real interest to me sort of at the time of the scoping project that social prescribing just occupied such a large part of the policy agenda, the health policy agenda. And I suppose, you know, whether there was scope to develop sort of similar momentum around health justice partnerships as an alternative model to support that drive to provide non-clinical support. It's probably no surprise that funding is down as a key challenge. So the short-term nature of funding, knowing what funding is available. Health commissioning budgets just seem to operate in a very particular way, and you know that's not necessarily a criticism of commissioners. It just seems to be the nature of the system that does create certain challenges. And I think yeah, the final one is just who to influence next. So I mean, as a relatively small voluntary organisation, the health system is complex and not necessarily easy to navigate. The structures are often similar but slightly different in different locations, and it's not always identify the right person to speak to about commissioning a new service or to speak to about promoting, you know, the benefits of this model. It's not always easy to understand sort of who does what, and who we can speak to next about taking it forward. But just, I suppose, just to end with opportunities, I think this point's already been made this morning, but you know, there are clear policy ambitions to address social determinants of health, including in maternity through the NHS equity and equality guidance, and health justice partnerships provide a really practical solution for doing that. I think we know that our service makes a real difference to women's lives in addressing social determinants of health. And you know, in maternity, those ambitions are there, but they're also there in the wider health system too, particularly with the development of integrated care boards. So it feels that there is a real opportunity to build momentum in how health justice partnerships can be a solution to improving social determinants of health. So thank you for listening today. As I mentioned, there are some resources on our website, but please do feel free to contact me as well if you're interested in finding out more about Maternity Action's work in this area. That's it from me. Thank you.
Thanks so much for that, Laura. I'm just going to dedicate a couple of minutes to questions before we move on. people saying that what you're saying about social prescribing having been championed over or in place of health justice partnerships is echoed in some people's experience. So obviously a link there that would be interesting for us to explore more. Just a couple of quick questions from me. In your experience, did you have kind of like a breakthrough moment where you felt like things were really able to progress, whether that's in terms of meeting the right person, hitting upon a key message, or kind of sharing that key piece of evidence? Was there anything in your experience that really made those breakthroughs possible?
I mean, yeah, it's hard to say. I think we were really fortunate to make those connections with the Cheshire and Merseyside Women's Health and Maternity Programme. So I think we were speaking with them about sort of broader work, and I think there were the colleagues sort of in the programme that just really got this connection between legal support and the impact on health. And I think as well, I think the Cheshire and Merseyside Women's Health and Maternity Programme had also done their own kind of scoping work, looking at what women and families wanted in their communities. And I think as part of that, they had evidence that, women and families were concerned with, employment and, money and things. So I suppose it was, fortunate that we were kind of speaking with them at the time when they were trying to solve a particular issue that related very well sort of to the Health Justice Partnership model as a solution. But I mean, it is, I would echo the points that were made earlier by what Hazel said about sometimes it just comes down to sort of finding a good contact that really gets it and can champion it. And I think that's the experience that I've had in this area too, that I think sometimes it's just fortunate that you're speaking to people that really understand what you're trying to do.
Fantastic. And one more quick question, if I may. It's kind of two questions linked together. Really share your excitement around the opportunity for this independent evaluation. Kind of a couple of thoughts around that. Do you have any ideas at this stage about what might be included or what focus areas you might be looking at as part of the evaluation? And I'm also interested in Maternity Action, as a national initiative, kind of taking on these projects, and to what extent you see it influencing your work as an organisation in the future.
Yeah, thanks, Martha. Two big questions. I think with evaluation, I think one thing that was on the slides actually, but I forgot to say, is that I think there is a real challenge with evaluation, and I think this is in the literature too. But I think there is a challenge just around sort of showing the health benefits of advice, and I think that's definitely something that we have grappled with sort of over the course of the project. We know that our service helps reduce stress for women. We know that stress in pregnancy is not good, but it's really hard to kind of find that evidence that I suppose shows that link to how the service benefits pregnancy outcomes. So I suppose I'm just really excited about working with NCVO to look at kind of those broader issues around evaluation, how we can kind of really focus on what the kind of key measures are for all of the partners involved in the project. I think with the work in the Wirral, we've got quite a lengthy evaluation survey. And my background is research, so I really love a survey, but it's not everyone does. So I think I'm just excited about working with NCVO to really try and focus on sort of what are the crucial evaluation measures that we should be trying to gather from sort of women and families using the service, but also from midwifery teams and our wider project partners, and continue those discussions around sort of how we demonstrate sort of the health benefits of this service for women and families. And then in terms of, sorry, could you just remind me of your second question?
Of course, yeah, it's just about how that might, the results of that evaluation might feed into Maternity Action's work more generally as a national organisation.
Yeah, I mean, I think we're really behind sort of health justice partnerships, and I think we're really keen to kind of further our work in this area. So I think any kind of evaluation that shows the value of that will sort of help us push that forward. We're really keen to, although we are a national organisation, I think it's really important to say that the projects being delivered locally are very much all around sort of embedding them in the local context. So it's about sort of working with the other local voluntary organisations that are already operating in the region. So as part of the Manchester project, for example, we're partnering with Greater Manchester Law Centre through that work. So that's something that we will continue to look at. But yeah, I mean, I think we are, we're a relatively small organisation. We have grown over the last few years, and it would be, yeah, great, I think, to sort of carry on growing the Health Justice Partnership work further.
Fantastic. Laura, thank you so much for coming and sharing your experiences. It's been so interesting to hear about your process of implementing these two different projects. And yeah, we look forward to hearing more about what these projects produce as well. Thank you.
Thanks, Martha. Thanks for the opportunity.
Thanks. So moving on then to our last section, what we want to do with this space is really revisit some of those tensions that we explored at the top of the meeting. It's clear that these partnerships are worth investment and other resourcing from both service funders and at the front line. So Hazel, I suppose our main question for this section is, what can we practically do to help make sure you don't have to keep repeating the same message and having the same conversations? What can we do at a strategic level to move this conversation forward?
Well, I think I have to say that I am more optimistic at the moment than I have been for quite a long time. As I said at the beginning, I've been working on this for several years and experienced all of the things that Laura mentioned, other people mentioned about fragmentation of decision making, everything being at a local level. I think that we are actually we have moved into a different kind of context. And I think one of the few good things that came out of the pandemic, and indeed has been amplified by the economic crisis, is the focus on health inequalities and the focus on poverty and the impact of poverty on health. So I think the climate has actually changed somewhat, and what I'm going to talk about a bit is that the statutory framework, particularly in the health sector, is very favourable for the development of health justice partnerships. So unusually for me, I do feel quite optimistic at the moment. I think it still needs a lot of driving forward. I'm going to share my screen because I've got a few more slides to show here. I'm hoping that you can, somebody tell me that you can see that as full. Can you see that? Yes. Full screen? Okay, brilliant, thank you. So what I'm talking about is kind of next steps. What I'm going to be focusing on, and just to reinforce again that I've been working with Sarah on a national strategy for health justice partnership. It's very grand sounding, but it was recognizing the fact that while looking at things at the local level, we need to try and get these kind of strategic conversations going on. And there are 4 aspects to our work that is funded by the Legal Education Foundation, and that's policy advocacy, which we have been working very, very hard on, and I think getting some traction. Providing advice and support for providers, thinking about developing the evidence base. I might come back to that later on, but also professional education. And what I want to deal with in this section, because I'm aware that we're slightly behind time, is to focus on the kind of policy context, but also to say something about professional education, because I think that addresses some of the issues that we've been talking about previously in terms of a lack of a shared vocabulary, a shared understanding between healthcare professionals, and social welfare legal providers, in terms of the fact that they are dealing with common problems and they need to take a kind of joined up approach. We have been helped a little bit by the tragic case of Awab Ishaq, who died as a result of mold. Got a huge kind of media storm, a lot of focus on this. It actually isn't the best case. It's not the best case to promote, because in fact there was some legal advice early on. But the point here that I want to make, the point that I've put here, is that in that tragic case of this poor child who was being made ill through horrendous mold in the flat, he says, we cannot tell you how many health professionals we have cried in front of. And this is to reinforce the point that healthcare professionals are critical noticers. They're not the solvers of problems, but they are there in a pivotal position to make a difference. The other thing that I wanted to mention, and this is not self-promotion, but in case anybody didn't see this, that there was a Law in Action programme about health justice partnerships with some very good examples in it a few weeks ago, and I think it's still available on BBC Sounds. But why do I think now is the time for strategic action? So I think there has been a change in thinking post-pandemic and economic crisis. There has been a change in thinking around within the Ministry of Justice on how we provide legal support. I've seen lots and lots of comments in the chat about the loss of legal aid, and we are all aware of it and we all worry about that. But thinking about that, I know that the Ministry of Justice has been thinking hard about how do we mitigate what we now recognise as the downsides of the loss of legal aid, and how can we best provide legal support. And actually health justice partnerships have become a part of that thinking. A very big change for me, I put on here NHS social prescribing, and yes, that's had a lot of traction. But for me, the very big change has been the Health and Care Act 2022. And I think for health justice partnerships, this is pivotal. The Health and Care Act 2022, it created, people have referred to integrated care systems and integrated care boards. The word integrated tells you immediately the focus of this act, and it's this act is a recognition of the need for health services to join with other services, other non-medical services, other non-traditionally medical services, to provide or to address in a holistic way both the immediate presenting health problems, but also the underlying causes, which may well be socioeconomic causes for which the law provides a remedy. And under the Health and Care Act, for some reason my thing's gone, it's got a life of its own today, I don't know why, but anyway, under the Health and Care Act, there is a statutory responsibility on integrated care systems, integrated care boards and partnerships to look around and to see who they can partner with in order to provide this kind of holistic service delivery. This is an example, this is a diagram, one of these sort of complex diagrams that you tend to get in the health sector, about how integrated care boards work with integrated care partnerships and all the rest of it. But the two red arrows, if you can see them, point to the places where there is real scope for collaboration between the health sector and the voluntary sector, the free social welfare legal service providers. And at the moment, or actually recently, integrated care systems and their boards have been developing their strategies. They have been thinking about, they are under a statutory duty to address health inequalities, and to do this through, one of the ways that they do this is through partnering with other organisations. And this provides a real opportunity, because actually the boards, the membership of the boards, and I don't know if there's anyone in the room who's on one of these boards, are looking for people to partner with. They're thinking about what kind of practical interventions are there. And I've been talking to people on these boards, so has Sarah. And one of the things that we've been saying to them is that actually you don't have to invent something new. We have got interventions out there that, like health justice partnerships, that exist. They are there. They lack capacity to do more, but they are there. And so you don't have to reinvent the wheel. The point is, find out what's in your area, decide what kinds of priorities you have for the kinds of people, the kinds of groups, or the kinds of conditions that you want to focus on, that you feel should be the focus of your activity. And then think about the organisations that you can partner with in order to deliver interventions that will improve health and well-being. So there is a real opportunity to work with these new boards, the partnership, the systems, the boards, and the local partnerships. And I think that there are people who are working on those strategies at the moment who are keen to talk, and I've experienced it myself, that people are coming to me to say, can we have a conversation about what we might do, how would we go about it, and those kinds of things. That's why Sarah's pamphlet is so helpful. But so this is a moment when actually the health sector is coming to other services to say, actually, what can we do? And they are interested in health justice partnerships. And I think from our point of view, that's really very important. Now, at the same time, in the legal services context, the conversations going on in the Ministry of Justice around legal support are focusing very much on early resolution, on targeted assistance, and thinking about the integration of services with healthcare, including co-location of services. And what all of us are keen on, what all of us want, is early intervention. It's avoidance of crises occurring. That's what we want. And the more you can get this kind of integration, the more able you are going to be to avoid difficult situations or to help to mitigate situations that have already occurred. So I think there is a coming together of the thinking within the health sector, and the thinking within the legal services context, which I think makes it an extremely favourable environment for promoting health justice partnerships. I take the point that Laura's made, and I have made this point myself over and over again. There is a problem about language, about understanding. So my experience of working with people in the health sector is very often that they don't really understand. When I talk about a health justice partnership, they immediately start thinking about prisons, or they immediately start get anxious about medical negligence or something, that we lack of. So whereas social prescribing immediately hits the spot with medical people, they may not know what it is, but they recognise the prescribing work, health justice partnership does not have that same resonance, and there is a real problem. And that's why I'm going to go on quickly to the need for education, because I do think that that's very important. But I also think that we need to work on getting this better embedded into the psyche of people who don't really understand what we're talking about in health justice partnerships. What I would say is that I do say that the Scottish Government is way ahead, has been way ahead of us on this for quite a long time. They actually use a different language. They use welfare advice and health partnerships, which probably is a better descriptor. And they have already made significant investments. And, you know, when somebody said to them, how did you do it in Scotland? They said, well, we just did. And they have invested a reasonable amount of money in doing this, and Nicola Sturgeon in 2022 actually extended that funding. And it was a recognition is that if you provide welfare advice in the same location that people are already receiving mental and physical health support, you give people with the best possible access to the services. So going on now quickly to the need for professional and interprofessional education. Laura mentioned, and I've showed this slide before, that recognising the need for legal assistance is not intuitive to health professionals. Why should it be? And when you talk, there is a kind of historic suspicion, certainly on the part of the medical profession, around lawyers. And when you say law or justice, they immediately start thinking about medical negligence. So there is an anxiety around it. And there's a need to get over that and to build greater trust. Obviously, it works in many places, but not always. And there's still a job to be done on that. And I think certainly through medical education, this is one way of addressing it. So lots of students will learn about social determinants of health, but in that context, they talk kind of theoretically about social determinants of health, and they don't necessarily talk very much about interventions. And speaking from my own experience, I've developed a little module at UCL that all medical students are required to take in their 5th year, whether they like it or not. They have to spend 3.5 hours listening and thinking and talking about health justice partnerships in the context of mitigating social determinants of health. So I think that medical education, so initial medical education and continuing education, should be a focus if we're thinking about what happens next, because what that does is to it helps to raise the consciousness of healthcare professionals. It helps to kind of get this language into their minds and help them to understand their position. So traditional focus of medical education has always been on kind of knowledge-based learning. That's true in law as well. And there is a move to more context-based problem-solving education. And so there is scope for this. My understanding is that I think UCL is pretty much the only medical school, because of the work that we've been doing, is the only medical school that actually provides this learning to students. And one of our ambitions is to develop something that we can kind of roll out to other medical schools and say, you know, here's a kind of module, how about it, what do you think? And this is, there's been a lot of progress made on this in the States. And it's important because for a healthcare professional to be able to be an active collaborator in the way that Sarah mentioned in a health justice partnership, they need to have certain knowledge, they need to have skills, they need confidence to analyse the root causes of problems. They need the confidence to ask certain kinds of questions about what is underlying the condition that someone is bringing to them. So the idea is that clinicians should be able to do kind of team-based problem solving for complex patients, working with social welfare legal advisors or with other advisors. They need to have some kind of knowledge of community resources, unless they have a link worker in their practice, which one would hope that they ought to have, we don't know, and to develop partnerships. And also clinicians can become advocates for policy and system change, because ultimately what you're talking about is a different way of delivering services and a kind of a modified way of delivering a holistic and effective service for some of your most challenged patients. And what we need to do is to break down kind of, I think disciplinary silos are breaking down, and people need to recognise the value of interprofessional education. And I've got to say that when I do some of my seminars with the medical students, one of the things that, in fact, every single time somebody will say to me, oh, can I spend some time in your Centre for Access to Justice? I would really love to do some of this work. And what we're working towards in due course is to try and teach medical students together with law students so that they can begin to understand each other. And the important thing is that the legal and medical professionals share core values. There may be this kind of historic suspicion, but they share core values, the kind of fiduciary duty to your patient or your client, the importance of evidence-based decisions, the value of professional judgment experience, all of these kinds of things, and a growing focus on social inequality and the effect of that on health. And more people, and particularly people coming into those professions, very much more engaged with social inequity, issues around social inequity. So what we need, if you say, where do we need to go? We need coordinated policy at a kind of strategic level, a focus on benefit to citizens, to the patients, the citizens. We need to think about how we deliver funding, how we do evaluation. I think there's a whole conversation around evaluation and what constitutes evidence in this field. How much evidence do you need of what kind? And I really do think a growing focus on professional education and interprofessional education. So I'd rather gallop through that because I'm aware that we're running out of time. But anyway, if anyone's got any questions, that's fine. And I'll stop sharing my screen now. Ooh. Okay, I think I've done it.
Excellent. Hazel, thank you so much. That's been really, really excellent. Thank you for giving us all a little bit of a mission to take forward. I know it's certainly something that we can continue to press our colleagues at the Ministry of Justice on in terms of how they're working towards better partnership. I thought the point around public legal education and a real focus on that was really, really interesting, and particularly interested, I don't know if any colleagues from the Clinical Legal Education Organisation are on the call today, but that might be a great network to take up that gauntlet of seeing how they can take forward an interdisciplinary approach to their clinical legal education work and how they can work as advocates for health justice education with across their university, essentially. And yeah, we'll eagerly await the development of more evaluation and discussions around the evidence that is producing. So we've done a real canter through in the hour and a half. Thank you so much, Hazel, Laura, Sarah, for sharing your insights, your experiences with us and taking us through the practicalities of where our collective focus needs to be in order to see progress and development. Thank you so much to all of our attendees too. I hope you found the session useful. Again, a particular thank you to our healthcare colleagues for joining us and for sharing our interest in progressing our work in these areas. We will be sending around a survey to gather your thoughts and feedback on the session to see how we can improve and what we might want to use these sessions for moving forward. The next Insights and Learning session will be on Tuesday, the 25th of July at the same time from 10 to 11:30. And we will be looking at triage systems, both face-to-face and remote level. And if you have any thoughts on future sessions, we'd always be interested to hear them. So huge thanks to you all again. And yeah, we look forward to seeing you at future events, and I wish you a wonderful rest of your week. Thanks, everyone.